This is Justine Sparrgrove recording Chapter 15, Schizophrenia Spectrum and Other Psychotic Disorders. The term schizophrenia was coined in 1908 by the Swiss psychiatrist Eugen Bleuler. The word was derived from Greek schizo, or split, and phren, meaning mind. Over the years, much debate has surrounded the concept of schizophrenia. Various definitions of this disorder have evolved, and numerous treatment strategies have been proposed, but none have been proven to be uniformly effective or sufficient. Schizophrenia is probably not a homogeneous disease entity. The Diagnostic and Statistic Manual of Mental Disorders supports this by describing schizophrenia as a schizophrenia spectrum. Schizophrenia spectrum disorders may have several causative factors, including genetic predisposition, biochemical dysfunction, physiological factors, and psychosocial stress. There is not a single treatment that cures this disorder, and effective treatment requires a comprehensive multidisciplinary effort, including pharmacotherapy and various forms of psychosocial care such as living skills and social skills training, rehabilitation and recovery, and family therapy. Differences between schizophrenia and other mental illnesses. Of all the mental illnesses, schizophrenia is probably responsible for lengthier hospitalizations, greater chaos in family life, more exorbitant costs to individuals and governments, and more fears than any other. Because of this threat to life and happiness and its relatively unknown causes, it's probably been studied more than any other mental disorder. Potential for suicide is a major concern among patients with schizophrenia. About 1/3 of people with schizophrenia attempt suicide, and about 1 in 10 die from the act. Psychosis is a severe mental condition in which there is disorganization of the personality, deterioration in social functioning, and loss of contact with or distortion of reality. There may be evidence of hallucinations and delusional thinking. Psychosis can occur with or without the presence of organic impairment. Clients suffering from schizophrenia demonstrate characteristics resulting in severe deterioration of social and occupational functioning. Symptoms generally appear in late adolescence or early adulthood, although they may occur in middle or late adulthood or adult life. The pattern of development of schizophrenia may be viewed in 4 phases: the premorbid phase, the prodromal phase, the active psychotic phase or schizophrenia, and the residual phase. Phase 1, the premorbid phase. Premorbid signs are those that occur before there is a clear evidence of illness and may include distinctive personality traits or behaviors. Traits that have been noted, including being very shy and withdrawn, having poor peer relationships, doing poorly in school, and demonstrating antisocial behavior. Phase 2, the prodromal phase. Prodromal symptoms more clearly manifest as signs of the developing illness of schizophrenia. The prodromal phase of schizophrenia begins with a change from premorbid functioning and extends until the onset of psychotic symptoms. This phase can be brief, but most studies indicate that the average length of the prodromal phase is between 2 to 5 years. During this phase, the individual begins to show signs of significant deterioration in function. Social withdrawal is not uncommon here. Some adolescent patients develop sudden onset of obsessive compulsive behavior. Recognition of the behaviors associated with the prodromal phase provides an opportunity for early intervention with possibility for improvement in long-term outcomes. Phase 3, schizophrenia. In the active phase, psychotic symptoms are prominent. The criteria for schizophrenia include the presence of delusions, hallucinations, disorganized speech and behavior, or negative symptoms, as well as a decreased level of functioning in areas of work, personal relationships, or self-care. Phase 4, the residual phase. Schizophrenia is characterized by periods of remission and exacerbation. A residual phase usually follows an active phase of the illness. During this phase, symptoms of the active phase are either absent or no longer prominent. Negative symptoms may remain, and residual impairment often increases between episodes of active psychosis. Prognosis of clients with schizophrenia. A complete return to full premorbid functioning is not common. However, several factors have been associated with a more positive outcome. These factors include good premorbid functioning, later age at onset, female gender, abrupt onset of symptoms with obvious precipitating factor, associated mood disturbance, rapid resolution of active phase symptoms, minimal residual symptoms, absence of structural brain abnormalities, normal neurological functioning, and no family history of schizophrenia. The cause of schizophrenia is still uncertain. No single factor can be implicated in the etiology, but instead the disease may result from a combination of factors. Biological factors related to schizophrenia. The lifetime risk for developing schizophrenia is about 1%, but studies have shown siblings of a client with schizophrenia have a 10% risk, and offspring with one parent with schizophrenia have a 5 to 6% chance. How schizophrenia is inherited is uncertain, and no definitive biological marker has ever been found. Studies are ongoing to determine which genes are important in the vulnerability to schizophrenia and whether one or many genes are implicated. The dopamine hypothesis suggests that schizophrenia may be caused by an excess of dopamine-dependent neuronal activity in the brain. This excess activity may be related to increased production or release of the substance at the nerve terminals, increased receptor sensitivity, too many dopamine receptors, or a combination of these mechanisms. Various other biochemicals have been implicated in the predisposition to schizophrenia. Abnormalities in the neurotransmitters are norepinephrine, serotonin, acetylcholine, and gamma-aminobutyric acid, and in the neuroregulators such as prostaglandins and endorphins have been suggested. Excess of serotonin has been hypothesized to be responsible for both positive and negative symptoms of schizophrenia, and the effectiveness of medications like clozapine leads to support this idea. The effect of autoimmune antibodies in the brain is being studied within the field of psychoneuroimmunology and suggests that these may be responsible for the development of at least some schizophrenias following infection from neurotoxic virus. Structural brain abnormalities have been observed in individuals with schizophrenia. Ventricular enlargement is the most consistent finding. However, some reductions in gray matters in the brain are also reported. MRI has revealed reduced symmetry in several lobes of the brain and reductions in size of structures within the limbic system in clients with schizophrenia. Some studies have reported a link between schizophrenia and epilepsy, Huntington's disease, birth trauma, head injury in adulthood, alcohol abuse, cerebral tumor, cerebrovascular accidents, systemic lupus erythematosus, myxedema, Parkinson's, Wilson's disease, Wilson's disease, and various hormonal deficiencies. So essentially anything related to the neurons in the brain or anything that affects the neurons. Psychological factors related to schizophrenia. Early conceptualizations of schizophrenia focused on family relationship factors as a major influences in the development of illness, but researchers now focus their studies in terms of schizophrenia as a brain disorder. Even though family relationships are not involved in the etiology of the illness, the symptoms in schizophrenia can contribute to significant disruption in communication and relationships among family members, so psychosocial factors should always be a part of comprehensive assessment. Environmental factors related to schizophrenia. Many studies have been conducted that have attempted to link schizophrenia to social class. Statistics have shown that a greater number of individuals from the lower socioeconomic classes experience symptoms associated with schizophrenia. Explanations for this occurrence include the conditions associated with living in poverty, such as congested housing, accommodations, inadequate nutrition, absence of prenatal care, few resources for dealing with stressful situations, and feelings of hopelessness for changing one's lifestyle poverty. An alternative view is that of the downward drift hypothesis, which suggests that because of the characteristic symptoms of the disorder, individuals with schizophrenia have difficulty maintaining gainful employment. Proponents of this view consider poor social condition to be a consequence rather than a cause of schizophrenia. There is no scientific evidence to indicate that stress causes schizophrenia, but it is probable that stress may contribute to the severity and course of the illness. It is known that extreme stress can precipitate psychotic episodes. Stress may indeed precipitate symptoms in an individual who possesses a genetic vulnerability to schizophrenia. Both cannabis and synthetic cannabinoids can induce many schizophrenia-like symptoms, and in individuals with pre-existing psychosis, cannabinoids can exacerbate symptoms. The increased risk for psychotic disorders like schizophrenia with cannabis use suggests the influence of lifestyle factors in the expression of genes. No single theory or hypothesis supports a clear-cut explanation for the disease. The more research that is conducted, the more evidence is compiled to support the concept of multiple causation in the development of schizophrenia. The most current theory seems to be that schizophrenia is a biologically based disease, the onset of which is influenced by factors within the environment. The DSM-5 identifies a spectrum of psychotic disorders that are organized to reflect a gradient of psychopathology from least to most severe. Delusional disorders is characterized by the presence of delusions that have been experienced for at least 1 month. Hallucinations are not prominent and behavior is not bizarre. So subtypes include erotomanic type. The individual believes that someone, usually of higher status, is in love with him or her. Famous persons are often the subject of erotomanic delusions. Then there's grandiose type. Individuals with grandiose delusions have irrational ideas regarding their own worth, talent, knowledge, or power. They may believe that they have special relationships with famous persons or even assume the identity of a famous person. Grandiose delusions of religious nature may lead to assumption of the identity of a deity or religious leader. Jealous type. Jealous delusions center on the idea that a person's sexual partner is unfaithful. The idea is irrational and without cause, but the individual with the delusion searches for evidence to justify the belief. The sexual partner is confronted regarding the imagined infidelity. Then there's persecutory type, and persecutory type delusions are the most common type. Individuals believe that they're being persecuted or badly treated in some way. Frequent themes including plotted against, cheated, defrauded, followed, and spied on, poisoned, or drugged. Repeated complaints may be directed at legal authorities, lack of satisfaction from which may result in violence towards the object of the delusion. Somatic type. Individuals with somatic delusions believe they have some type of general medical condition. And then there's mixed type. When the disorder is mixed, delusions are prominent, but no single theme is prominent. Brief psychotic disorder is identified by the sudden onset of psychotic symptoms that may or may not be preceded by a severe psychosocial stressor. These symptoms last at least 1 day, but less than 1 month, and there is an eventual full return to a normal level of functioning. Evidence of impaired reality testing may include incoherent speech, delusions, hallucinations, bizarre behaviors, and disorientation. Catatonic features may also be associated with this disorder. Substance-induced psychotic disorder. This disorder involves prominent hallucinations and delusions, which are directly attributed to substance intoxication withdrawal after exposure to a medication or a toxin. When the symptoms are more severe than those typically found in intoxication or withdrawal syndrome, this diagnosis is made. The medical history, physical examination, or laboratory findings provide evidence that the appearance of the symptoms occurred in association with substance intoxication or withdrawal or exposure to medication or a toxin. So if you want to look at a list of substances that are believed to induce psychotic disorders, they can be found on table 15.1 in your text. Psychotic disorder due to another medical condition. Medical conditions such as CNS infections, hypo or hyperthyroidism, migraine headaches, and renal disease can cause psychotic symptoms such as prominent hallucinations and delusions. Note that this diagnosis should not be made if the symptoms occur during the course of delirium. Catatonic disorder is diagnosed when symptoms such as stupor, catalepsy, waxy flexibility, mutism, and negativism are present. A full list of those symptoms can be found in box 15.1 in your text. Catatonic disorder may be associated with other psychotic disorders as well, and catatonic disorders affects the physical ability. Catatonic disorder is also associated with medical conditions, including metabolic disorders such as hepatic encephalopathy, hypo and hyperthyroidism, hypo and hyperadrenalism, and vitamin B12 deficiency, and neurological conditions such as epilepsy, tumor, cerebrovascular disease, head trauma, and encephalitis. Schizophreniform disorder. The features of this disorder are identical to those of schizophrenia, but the duration, including prodromal, active, and residual phases, is only between 1 and 6 months. If the diagnosis is made while the individual is still symptomatic, but has been so for less than 6 months, it is qualified as provisional. The diagnosis is changed to schizophrenia if the clinical picture persists beyond 6 months. Schizoaffective disorder. This disorder includes symptoms of schizophrenic behaviors with strong symptoms also associated with mood disorders like depression or mania. The client may appear depressed with psychomotor retardation and suicidal ideation, or symptoms may include euphoria, grandiosity, which is unrealistic sense of superiority, and hyperactivity. The decisive factor in this diagnosis of schizoaffective disorder is the presence of hallucinations and/or delusions that occur for at least 2 weeks in the absence of a major mood episode. Prominent mood disorder symptoms must be evident for a majority of the time. All right, let's check your understanding. A client is admitted with diagnosis of brief psychotic disorder with catatonic features. Which symptoms are associated with catatonic specifiers? Strong ego boundaries and abstract thinking, ataxia and akinesia, stupor, muscle rigidity and negativism, and substance abuse and cachexia. So the correct answer is C. Symptoms associated with the catatonic specifier include stupor, muscle rigidity, or excessive purposeless motor activity, waxy flexibility, negativism, echolalia, and echopraxia are also common behaviors. Positive symptoms. In the first step of nursing process, the nurse gathers a database from which nursing diagnoses are derived and a plan of care is formulated. So positive symptoms for a client with schizophrenia. Symptoms of schizophrenia are commonly described as positive or negative. Positive symptoms tend to reflect an alteration or distortion of normal mental functioning. Positive symptoms are associated with normal brain structures on computed tomography scans or CT scans and relatively good response to treatment. Let's look at content of thought. The client continues to have delusions in spite of obvious proof that the beliefs are false or irrational. Delusions are subdivided according to their content. Common types include delusions of persecution, delusions of grandeur, delusions of reference, delusions of control or influences, somatic delusions, or nihilistic delusions. Individuals with paranoia have extreme suspiciousness of others and of their actions or perceived intentions. Magical thinking describes when the client believes that his or her thoughts or beliefs have control over specific situations or people. Form of thought. Associative looseness is characterized by speech in which ideas shift from one unrelated subject to another, and the individual is unaware that the topics are unconnected. When the condition is severe, speech may be incoherent. The person may invent new words or neologisms that are meaningless to others but have symbolic meaning to the individual. Concreteness or literal interpretations of the environment represents a regression to earlier level of cognitive development. Abstract thinking becomes very difficult. Choice of words is governed by sounds, and clang associations often take the form of rhyming. A word salad is a group of words that are put together randomly without any logical connection. For example, most forward action grows life double plays circle uniform. With circumstantially, the individual delays in reaching the point of a communication because of unnecessary and tedious details. The point or goal is usually met, but only the numerous interruptions by the interviewer to keep the person on track of the topic being discussed. Tangentially differs from circumstantially in that the person never really gets to the point of the communication. Unrelated topics are introduced and the focus of the original discussion is lost. Mutism is an individual's inability or refusal to speak. All right, let's check your thinking. The client hears the word match. The client replies, a match? I like matches. They're the light of the world. God will light the world. Let your light so shine. Which communication pattern does the nurse identify? Word salad, clang association, loose association, or ideas of reference? The correct answer here is C. Loose association is characterized by communication in which ideas shift from one unrelated topic to another. The situation in the question represents this communication pattern. Perception. Hallucinations may involve any of the five senses. Types of hallucinations include the following. Auditory hallucinations are false perceptions of sound. Most commonly, they are voices, but the individual may report clicks, rushing noises, music, and other noises. Voices that issue commands for violence to self or others may or may not be heeded by the psychotic person. Auditory hallucinations are the most common type. Visual hallucinations may consist of formed images such as people or of unformed images such as flashes of light. Tactile hallucinations are false perceptions of the sense of touch, often something on or under the skin. One specific tactile hallucination is formication, the sensation that something's crawling on or under the skin. Gustatory hallucinations are false perceptions of taste. Most commonly, gustatory hallucinations are described as unpleasant taste. And then olfactory hallucinations are false perceptions of the sense of smell. Illusions differ from hallucinations in that they are misperceptions or misinterpretations of real external stimuli. Sense of self. Clients with schizophrenia may lack a feeling of uniqueness and experiences a great deal of confusion regarding his or her identity. A client with schizophrenia may repeat words that he or she hears, which is called echolalia. This is an attempt to identify with the person speaking. Identification, which occurs on an unconscious level, and imitation, which occurs on a conscious level, are ego defensive mechanisms which are used by individuals with schizophrenia and reflect their confusion regarding self-identity. Because they have difficulty knowing where their ego boundaries end and other persons begin, their behavior often takes on the form of that which they see in the other person. The unstable self-identity of an individual with schizophrenia may lead to feelings of unreality, for example, feeling that one's extremities have changed in size, or a sense of seeing oneself from a distance. Let's check your understanding. A client diagnosed with schizophrenia experiences identity confusion and communicates with a nurse using echolalia. What is the client attempting to do by using this form of speech? Identify with the person speaking, imitate the nurse's movements, alleviate abolition. The correct answer here is A. Echolia is a parrot-like repetition of overheard words or fragments of speech. It is an attempt by the client to identify with the person who is speaking. Negative symptoms. Negative symptoms reflect a loss of normal functions. Atypical antipsychotics have been advanced as being more effective in treating negative symptoms, but researchers continue to search for medications to treat cognitive deficits that can be problematic for patients with schizophrenia. These deficits include memory, attention, language, and executive function, and have been identified as particularly problematic for individuals with regard to overall functional ability. Affect. Affect describes the behavior associated with an individual's feeling, state, or emotional tone. Affect is inappropriate when the individual's emotional tone is incongruent with the circumstances. Affect is described as a bland or flat when the emotional tone is very weak. The client with schizophrenia often demonstrates an indifference to or disinterest in the environment. The bland or flat affect is a manifestation of the emotional apathy. Volition. Impaired volition has to do with the inability to innate goal-directed activity. In the individual with schizophrenia, this may take the form of inadequate interest, motivation, or ability to choose a logical course of action in a given situation. Ambivalence and the client with schizophrenia refers to the coexistence of opposite emotions towards the same object, person, or situation. These opposing emotions may interfere with the person's ability to make even a very simple decision. Personal grooming and self-care activities may be neglected. The client with schizophrenia may appear disheveled and untidy and may need to be reminded of the need for personal hygiene. Interpersonal functioning and relationship to the external world. Impairment in social functioning may be reflected in social isolation, emotional detachment, and lack of regard for social conventions. Some clients with acute schizophrenia cling to others and intrude on the personal space of others, exhibiting behaviors that are not socially and culturally acceptable. Individuals with schizophrenia sometimes focus inward on themselves to exclusion of the external environment. Some individuals lack awareness of their being any illness or disorder, even when symptoms appear obvious to others. The term for this is anosognosia. Psychomotor behavior. Anergia is a deficiency of energy. The individual with schizophrenia may lack sufficient energy to carry out activities of daily living or to interact with others. Waxy reflexibility describes a condition in which a client with schizophrenia allows body parts to be placed in a bizarre or uncomfortable position. Once placed in the position, the arm, leg, or head remains in that position for long periods, regardless of how uncomfortable it is for the client. The symptom is manifested by the voluntary assumption of inappropriate or bizarre postures. Pacing back and forth and body rocking are common psychomotor behaviors of the client with schizophrenia. Associated features. Anhedonia is the inability to experience pleasure. This is particularly distressing symptom that compels some clients to attempt suicide. Regression is the retreat to an earlier level of development. Regression, a primary defense mechanism of schizophrenia, is a dysfunctional attempt to reduce anxiety. Nursing diagnosis and outcome identification. Using information collected during the assessment, the nurse completes the client database from which a selection of appropriate nursing diagnosis is determined. There are many client behaviors and the NANDA nursing diagnoses that correspond to those behaviors, which may be used in planning care for the client with schizophrenia or other psychotic disorders. A list of client behaviors and the NANDA nursing diagnosis that correspond with those behaviors are on table 15.3 in your textbook. So diagnosis and outcome: social isolation related to inability to trust, panic anxiety, weak ego development, delusional thinking, and regression can be one diagnosis. Risk for violence, self-directed or other directed, related to extreme suspiciousness, panic anxiety, catatonic excitement, rage reactions, and command hallucinations can be another one. Impaired verbal communication related to panic anxiety, regression, withdrawal, or disordered unrealistic thinking. Self-care deficit related to withdrawal, regression, panic anxiety, perceptual or cognitive impairment, inability to trust. Another one, disabled family coping related to difficulty coping with client's illness. Ineffective health maintenance related to disordered thinking or delusions. Impaired home maintenance related to regression, withdrawal, lack of knowledge or resources, impaired physical or cognitive functioning. Let's look at our outcomes. The following criteria may be used for measurements of outcomes in the care of the client with schizophrenia. So the client demonstrates an ability to relate satisfactorily with others, recognizes distortions of reality, has not harmed self or others, perceives self realistically, demonstrates the ability to perceive the environment correctly, maintains anxiety at a manageable level, and relinquishes the need for delusions and hallucinations. They may also demonstrate the ability to trust others, uses appropriate verbal communication in interactions with others, and perform self-care activities independently. Goals for treating disturbed sensory perception include discussing hallucinations, helping the client define and test reality, and verbalizing and understanding that the hallucinations are a result of client's illness. Interventions to achieve these goals include an attitude of acceptance, distracting the client from hallucinations, and avoiding reinforcement of the hallucinations. In this instance, it is evidenced by behaviors that indicate that the presence of delusional thinking, suspiciousness, and inaccurate interpretation of the environment. The diagnosis is defined as a disruption in cognitive operations and activities. Goals for treating disturbed thought processes include helping the client recognize and verbalize false ideas and helping the client differentiate between delusional thinking and reality. Interventions to achieve these goals include promoting the development of trust, focusing on reality, and maintaining an assertive yet genuine approach. Risk for self or other directed violence. Goals for treatment should include preventing the client from harming themselves or others. Interventions such as maintaining a low level of stimuli, assessing for presence of suicidal ideations or hallucinations that may be instructing the client to hurt themselves or others. Impaired verbal communication. Goals for treatment include helping the client remain on topic when talking and demonstrating the ability to carry on verbal communication in a socially acceptable manner. And interventions include facilitating trust and understanding in a non-threatening manner, orienting the client to reality as required, and avoiding abstract phrases and cliches. Let's check your understanding. To deal with the client's hallucinations therapeutically, which nursing intervention should be implemented? Reinforce the perceptual distortions until the client develops new defenses. Provide an unstructured environment. Avoid making connections between anxiety-producing situations and the hallucinations, or distract the client's attention. The correct answer here is D. The nurse should first empathize with the client by focusing on feelings generated by the hallucination, present objective reality, and then distract or redirect the client to reality-based activities. A client diagnosed with paranoid schizophrenia states, "My roommate is plotting to have others kill me." Which is the appropriate nursing response? I find that hard to believe. What would make you think such a thing? I know your roommate, he would not do such a thing. I can see why you feel that way. The correct answer here is A. This client is experiencing a persecutory delusion. This nursing response is an example of voicing doubt, which expresses uncertainty as to the reality of the client's perceptions. This is an appropriate therapeutic communication technique in dealing with clients who are experiencing delusional thinking. So, client and family education. Topics for discussion with clients and family include the nature of the illness, including what to expect as the illness progresses, ways for the family to respond, management of the illness, including appropriate medication management, when to contact the health provider, and daily living skills training. Management of the illness, connection of exacerbation of symptoms to times of stress, appropriate medication management, side effects of medication, importance of not stopping the medications, when to contact the healthcare provider, relaxation techniques, social skills training, daily living skills training. Support services, financial assistance, legal assistance, caregiver support groups, respite care, and home health care. Psychological treatments for clients with schizophrenia. Individual recovery-oriented psychotherapy and cognitive therapies are evidence-based interventions in treatment of clients with schizophrenia, but these should be adjunct to a multifaceted team approach. The primary focus on these cases must reflect efforts to decrease anxiety and increase trust. Once a therapeutic interpersonal relationship has been established, reality orientation is maintained through exploration of the client's behavior within relationships. Group therapy for individuals with schizophrenia has been shown to be effective, particularly with outpatients and when combined with drug treatment. Group therapy in inpatient setting is less productive. Inpatient treatment usually occurs when symptomology and social disorganization are at their most intense. At this time, the least amount of stimuli possible is most benefit for the client. Behavior modification has a history of qualified success in reducing the frequency of bizarre, disturbing, and deviant behaviors and increasing appropriate behaviors. Features that have led to the most positive results include clearly defining goals and how they will be measured, attaching positive, negative, and aversive and reinforcement to adaptive and maladaptive behaviors, using simple, concrete instructions and prompts to elicit the desired behavior. Social skills training is used to help clients manage struggles with interpersonal relationships and communications. Social dysfunction is a hallmark of schizophrenia. Considerable attention is now being given to the enhancement of social skills in these clients. Social treatments for clients with schizophrenia. The importance of the expanded role of the family and the aftercare of relatives with schizophrenia has been recognized, thereby stimulating interest in family intervention programs designed to support the family system, prevent or delay relapse, and help to maintain the client in the community. These psychoeducational programs treat the family as a resource rather than a stressor, with a focus on concrete problem solving and specific helping behaviors for coping with stress. These programs recognize the biological basis for schizophrenia and the impact that stress has on the client's ability to function. The recovery model has been used primarily in caring for individuals with serious mental illness, such as schizophrenia and bipolar disorder. However, concepts of the model are amendable to use with all individuals experiencing emotional conditions with which they require assistance and who have a desire to take control and manage their lives more independently. Whedon identifies two types of recovery with schizophrenia: functional and process. Functional recovery focuses on the individual's level of functioning in such areas as relationships, work, independent living, and other kinds of life functioning. He or she may or may not be experiencing active symptoms of schizophrenia at that time. The concept of recovery in schizophrenia remains controversial among clinicians, and many challenges lie ahead for continued study. Recovery models have similarities in that they both necessarily engage the support of multiple resources, but recovery models also highlight the dimension of active engagement and empowerment of the client in decision-making. Antipsychotic medications are also called neuroleptics and historically were referred to as major tranquilizers. They're effective in treatment of acute and chronic manifestations of schizophrenia and in maintenance therapy to prevent exacerbation of schizophrenic symptoms. Without drug treatment, an estimated 72% of individuals who have experienced a psychotic episode relapse within a year. This relapse rate can be reduced to about 23% with continuous medication administration. Select agents are used in the treatment of bipolar mania: olanzapine, aripiprazole, chlorpromazine, quetiapine, risperidone, azathioprine, and ziprasidone. The effects of these medications are related to blockage of number of receptors for which they exhibit various degrees of affinity. Blockage of the dopamine receptors is thought to be responsible for controlling positive symptoms of schizophrenia. Dopamine blockage also results in extrapyramidal symptoms. And prolactin elevation, cholinergic blockade, causes anticholinergic side effects like dry mouth, blurred vision, constipation, urinary retention, and tachycardia. Blockage of the alpha-1 adrenergic receptor produces dizziness, orthostatic hypotension, tremors, and reflex tachycardia. Histamine blockade is associated with weight gain and sedation. Extrapyramidal symptoms, or EPS, include pseudoparkinsonism, akinesia, akathisia, dystonia, and oculogeric crisis. Antiparkinsonian agents may be prescribed to counteract these. Proper client education related to antipsychotics. The client should use caution when driving or operating dangerous machinery. Drowsiness and dizziness can occur. Not stop taking the drug abruptly after long-term use. To do so might produce withdrawal symptoms such as nausea, vomiting, dizziness, gastritis, headache, tachycardia, insomnia, and tremors. Use sunblock lotion and wear protective clothing when spending time outdoors. Skin is more susceptible to sunburn, which can occur in as little as 30 minutes. Report weekly if receiving clozapine therapy, to have blood levels drawn and to obtain a weekly supply of the drug. Report the occurrence of any of the following symptoms to the physician immediately: sore throat, fever, malaise, unusual bleeding, easy bruising, persistent nausea and vomiting, severe headache, rapid heart rate, difficulty urinating, muscle twitching, tremors, dark-colored urine, excessive urination, excessive thirst, excessive hunger, weakness, pale stools, yellow skin or eyes, muscular incoordination, or skin rash. Rise slowly from sitting or lying position to prevent a sudden drop in blood pressure. Take frequent sips of water, chewing sugarless gum or sucking on hard candy if the mouth is dry and is a problem. Good oral care, frequent brushing and flossing is very important. And consult the physician regarding smoking while on antipsychotic therapy. Smoking increases the metabolism of antipsychotics, requiring an adjustment in dosage to achieve therapeutic effect. Avoid drinking alcohol while on antipsychotic therapy. These drugs potentiate each other's effects. Avoid taking the other medications, including over-the-counter products, without the physician's approval. Many medications contain substances that actually interact with the antipsychotics in a way that could be harmful. Be aware of possible risks of taking antipsychotics during pregnancy. Safe use during pregnancy has not been established, Antipsychotics are thought to readily cross the placental barrier, so a fetus could experience adverse effects of the drug, and inform the physician immediately if pregnancy occurs, is suspected, or is planned. Be aware of side effects of antipsychotic drugs. Continue to take the medication even if feeling well, and as though it is not needed. Symptoms may return if medication is discontinued. And carry a card or other identification at all times describing medications being taken. Now let's check your understanding. A client who has been taking Thorazine for several months presents to the emergency department with EPS of restlessness, drooling, and tremors. What medication will the nurse expect this physician to order? Paroxetine, carbamazepine, cogentin, or Ativan? The correct answer here is C. Benztropine is an anticholinergic medication that blocks cholinergic activity in the central nervous system, which is responsible for EPS. Anticholinergics are the drugs of choice to treat extrapyramidal symptoms associated with antipsychotic medication. And that is the end of our lecture today. So I will see you all in class.